So today's topic of discussion is mechanical ventilation in airway diseases. We had one patient which was extubated. He had COPD, but unfortunately we had to intubate again. So mechanical ventilation in airway diseases. So common airway diseases encountered in ICU are COPD and asthma. So what are the goals for mechanical ventilation in COPD patients or asthma patients? Goals are rest to respiratory muscles, avoid dynamic hyperinflammation, avoid overinflation and alkalemia. There are characteristic feature of airway in airway diseases. So in COPD and asthma patient, there is increased inspiratory airway resistance, increased expiratory airway resistance, loss of lung elasticity, dynamic narrowing and small airways, dynamic hyperinflation, and development of intrinsic PEEP or auto PEEP, respiratory muscle fatigue and weakness, deterioration of gas exchange at alveolar level, which include VQ mismatch, hypoxemia, decreased central venous oxygen concentration or saturation. So, what is dynamic hyperinflation or intrinsic PEEP? What happens during COPD? There is increased elasticity and more amount of air is remained, and the expiratory time is insufficient to expel this air. So over the time there is built up air or the air remains behind and development of auto PEEP or intrinsic PEEP. So what are the disadvantages of intrinsic PEEP? There is increased work of breathing, then diaphragm is fatigued, there is decreased venous return because of increased intrathoracic pressure, and ultimately decreased cardiac output. So it may result in pneumothorax and pneumomediastinum because of barotrauma. So what we do for that, we increase inspiratory expiratory ratio. So we increase the expiratory time so that air is expelled. So what are the lung mechanics what is difference between lung mechanics of the COPD and asthma patient? Actually in COPD there is loss of elasticity and there is increased airway collapsibility, but in case of asthma what happens, there is increased thickness and due to inflammation and decreased airway diameter, but collapsibility is less. There is no more collapsibility compared to COPD patient where airway collapsibility is more. Okay, so what are the ventilation strategies during this COPD and asthma patients? So in asthma relatively small tidal volume is required and high inspiratory flows are required, which are achieved with tidal volume of 6 to 10 ml per kg, inspiratory flow of 80 to 100 ml per minute, peak airway pressure 40 to 45 centimeters of H2O, alveolar plateau pressures are up to 20 to 30 centimeters of water, respiratory rate should be 8 to 12 breaths per minute. In case of COPD, and there is less structural airway flow obstruction, so tidal volume required is quite more, 9 to 10 ml per kg. Even respiratory rate is also required more, 14 to 16 breaths per minute. In both COPD and asthma, respiratory trigger sensitivity is minimal. So what kind of mode we will prefer during asthma and COPD patients? So modes commonly used are ACV and pressure control ventilation, which are preferred over pressure support ventilation. Mostly we should avoid control mechanical ventilation because it will cause early development of muscle atrophy and muscle damage. So what are the indications for intubation in COPD patient? So severe CO2 narcosis, then unconscious patient, hemodynamic instability, cardiorespiratory arrest, and these are the common indications for intubation of COPD patients. So what are the winning strategies or winning criteria for COPD and asthma patient? The winning criteria include minute ventilation less than 15 ml per kg, respiratory rate less than 30 per minute, tidal volume more than 325 ml, rapid shallow breathing index is less than 105, maximum inspiratory pressure minus 15 centimeters of H2, dynamic complex more than 22, static complex more than 33. These are few new terminologies we will discuss in future lectures and discussion. Okay, so these are the indications for weaning of COPD patients. Okay, thank you.